Hello, this is Dr. Erica Lewis, recording evidence-based strategies for DNP prepared nurse leaders. Welcome. I look forward to reviewing this content with you. This is some of the most difficult content that I have to conceptually think through as I explain to you. And it's this first part that's the most challenging. The rest of it, has a lot of evidence to inform it and gets easier. But this first part, sorting out the difference between innovation, quality improvement, research, and evidence-based practice, when each are needed, and then once what is needed is determined, deciding on how to implement that method appropriately based on which one was selected. That's the hardest thing. And I will tell you, there is lots of discussion and disagreement within the nursing and broader community about this. So there's not one easy answer. Keene did come out with this new inquiry framework that you see here and you read about in your readings for this study guide that I find to be very helpful. I also kind of have some of my own ideas, things I would add here or think about a little differently, and we'll learn those in a future slide. But just to get started, this part I have kind of circled in red of the inquiry framework I think is kind of spot on. So there's a trigger in a setting that makes the person, the clinician, believe that there's some sort of challenge, and there needs to be a process for confirming and deciding if there's a demand for that, a change, confirming there's a problem. There needs to be some studying, some inquiry into that trigger, and that includes a scan for a solution. So searching the evidence, searching the localized data. If there is no solution, that's when you go the generate new knowledge route, which is research, or use an innovation process to come up with ideas to implement in the setting. So all of that makes a lot of sense to me. And then if there is strong evidence, that's where you move into implementation, and what I'm going to call implementation science, because there is a strong body of evidence guiding implementation science. And implementation science essentially means that if there's enough evidence to warrant a change, you can study, implement that change differently than if there's not enough evidence to implement a change. And we use those implementation science methods when we have sufficient evidence. Now, this is where the model becomes perhaps slightly less useful, and I have some proposed changes here. So I agree that when there is enough evidence, you should either do quality improvement or evidence-based practice. However, I think it's a little muddy in this model when you choose which of the two. So when you would choose quality improvement is if there's clear localized data that there is a problem, perhaps some localized data indicating a possible solution, and then there should be some level of generalizable evidence to guide that change. We're not just, kind of picking something random to do. It needs to make sense with the localized data and with some sort of evidence out there. Now, evidence-based practice is kind of the opposite. There should be some localized data that there's a problem, but where you have your bulk of the evidence is the clear generalizable evidence to guide the change. And then you take one of these different paths. You either follow the quality improvement process of iterative small changes studying localized data, or you take the evidence-based practice step, which is creating a practice change and looking at the outcomes effect to that change. There are some similarities between these two, and there's some similarities between these two and research and innovation. Yet there are distinct bodies of theories and models and guides structuring these differently. So you need to understand when you should start down that path of using the theories, models, and kind of tools of evidence-based practice, and theories, models, and tools of quality improvement. Now, two additional little changes I would make here, not quite as applicable in this course specifically, but as you start to think about QI. Here in the JMU DNP program, we do program evaluation and policy analysis as two potential methods for implementing your DMP project. And I like to think of program evaluation and policy analysis as more specific subsets of QI. They both rely heavily on localized data in addition to some generalizable evidence. And so I feel that they fall best in the QI bucket. And then the other thing that I don't particularly prefer about this model is that process change kind of arrow you see into quality improvement. Quality improvement frameworks make it very clear that structural changes, process changes, and outcome changes are all part of quality improvement. And I didn't feel like that was completely clear in this model. So that would be a change I would propose. So there you can see the Keen model that I think is very helpful and some ideas I have about kind of clarifying points within that model. Now, the one thing I did want to come back to is this idea that quality improvement, evidence-based practice, innovation, and research all have certain parts of them that they share, and that can get really muddy and confusing to people. I have 2 points I want to make on that. First, it's a lot easier, in my opinion, to decide if you're in the forefront with a question, figure out where you need to go with your models to use than it is once you've decided those models, getting into the nitty-gritty of studying your outcomes and looking at making that change. That's where a lot of mixing of methods comes in my opinion. And we'll come back to this in our proposal writing module or study guide, towards the end of this class. The other thing, and I'll reference an article you probably haven't seen, but you will read in a future class by Margaret Sandalowski, who is like the mother of qualitative nursing research. She wrote an article talking about descriptive qualitative research, which is one of the more basic methods of qualitative research. And she talked about how people were kind of borrowing little bits of other types of qualitative research, whether it's ethnography or whatever it is, and then calling it that instead of, when they were using the bulk of the qualitative descriptive methods with these little kind of lenses from these other things, they should have been calling it qualitative descriptive research. And there's nothing wrong with that kind of more basic method. And I would apply that same idea here, that if we start to call something, an innovation evidence-based practice, that gets really confusing to me. Whereas I'd rather say, evidence-based practice methods were used, innovation techniques were borrowed at the start of the project to blah, 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 study the trigger, whatever it is. So I'd rather make it very clear when what methods were used. And again, there's a lot of muddiness in this, in the science, in the discipline. And so this isn't something you have to be able to just wave a magic wand and figure out. But I do encourage you, as you look at research, to kind of look for these different methods and figure out how people are talking about them and how you can best talk about it when you write about your changes as a DMP scholar, so that you can be clear with what you did and rely on good tools and make it clear what tools you used when you publish. All right. This table comes from your reading, which is a chapter on leading evidence-based practice that I think will be a really helpful chapter for you as you think about leading evidence-based practice in your settings. It's going to be one of your main tasks as a DMP prepared nurse leader. But I wanted to kind of parallel this process with what we're doing in the class. We will be talking about an introduction to evidence-based practice now and guidelines for implementing evidence-based practice now and in the proposal writing module. And then this kind of last 4 points, the appraising the evidence, the searching for the evidence, appraising the application of the evidence, and summarizing evidence, that is all covered in the literature review module in this course. And part of the reason for that is that although many folks have had some exposure to this, I find that most folks are not proficient at this or competent at this. And so we need to keep iterating and doing this and figuring out how to integrate best practices into this evidence gathering and synthesizing in order to move forward with a strong evidence-based practice. And we also, part of the reason I focus on this heavily in this course is that this part, this evidence kind of gathering and appraising and summarizing, it needs to be done for every type of DMP model, project kind of method model, whether that's QI, evidence-based practice, program evaluation, or policy analysis. All of them have some level of evidence that's incorporated, and so those techniques will really serve you well, and the work can serve you well if you choose to move forward with the work you create in this class. All right, thinking a little bit about evidence-based practice background. We all kind of have been exposed to a lot of these points. It takes a ridiculously long time, 15 to 20 years, depending on what study you look at, whether you're talking about drugs or devices or practice changes, to get evidence into practice. And that is just crazy. It's especially crazy thinking through how rapidly new knowledge is now being generated. I mean, we're having new knowledge generated before many places have implemented the knowledge that came out before the most recent generated knowledge. And it's just very confusing. There's also novel methods and thinking, AI, that are at times difficult to evaluate the knowledge being generated. And that's adding a layer of confusion, I think, is going to be a really important thing for nurse leaders and healthcare leaders to sort out moving forward. Super interesting study. I'll digress for a second because you know how much I love technology and stuff. There's a really interesting study where they tried to study whether AI could predict cardiovascular risk looking at the vessels in people's eyes. And it could. It was equally proficient as humans. However, there was this bizarre kind of side finding in this study where the researchers noticed that the AI could also predict the gender, the assigned at birth gender of the participant. And neither the researchers didn't know how AI could do it, but it was a verifiable thing. They could see it could do it accurately. So that's just blows my mind a little bit. How do you incorporate new knowledge if you don't even understand how that computer generated the knowledge? And then we also know automated intelligence makes stuff up sometimes. So if you don't know how it's making that decision sometimes, how do you know if it's making it up or if it's knowing something that humans can't know? And I find that to be completely fascinating and slightly disturbing. And anyways, I'll stop digressing. But final point here is that the U.S. health system spends a higher proportion of its GDP than any other country in the whole world. But we rank 37 out of 191 countries on our performance of outcomes. Just to compare, the United Kingdom spends 6% of their GDP. Remember, and they are ranked 18th. So there's lots of problems in our system, and we're not creating the outcomes we've desired, and evidence-based practice is one solution to that problem. So what is evidence-based practice? Evidence-based practice is a problem-solving approach to clinical decision-making within a healthcare organization. It includes best scientific evidence and best experiential evidence, whether that's patient experience or clinician experience. And this definition has evolved over time to be very inclusive of that experiential evidence, which I think is a really positive change. And I would also add, when you think of the healthcare organization, there's lots of layers there. So evidence-based practice can be at all of these layers. You can think about evidence-based practice as a bedside change, something that an individual clinician applies with an individual patient, or you can broaden that out to be a systems change. And that's part of one of the benefits I see in evidence-based practice. It's also one of the challenges that happens when we talk about using evidence-based practice methods, because the way we might implement an evidence-based practice decision in a one-on-one interaction with a patient could look really different than the way we would implement an evidence-based practice change that's a system-wide change. So I find that to be a nice flexible part of an EBP, but also one that makes implementation a little more challenging. The clinician's role is to seek multiple sources of knowledge throughout the EBP process, looking at evidence, clinical expertise, and patient preference as all important aspects of that. And I think, when it comes to clinical expertise and patient preference, we do a really nice job at, we've gotten really good in many settings at including patient preference in those individual kind of EBP applications, applying with an individual patient. I am less confident in what I see happening in systems change that we are incorporating patient preference. And I have some ideas for why. You can probably think about why that's harder, but I do want to push you as you think about EBP changes to consider how patient preferences could be incorporated. I personally think that's a great place for innovation, is relying on some of the innovation models that are well suited for incorporating large variety of stakeholder feedback into change. So I think that could be one option, and I'm not going to get into that here because that's not really the focus of this class, but I do think that's a place where there should be some growth in the future. So it is also very clear that nurse leaders must lead interdisciplinary teams to improve practice. This is going to be your role as a DNP prepared nurse leader. This is the thing you do. This is what you need to get good at. And so that's what we're going to do. All right, this is the Johns Hopkins evidence-based practice model. Just to define a few things in this, you've looked at this in your study guide, so I'm going to go through this kind of quickly. Inquiry is a spirit of curiosity. It's a foundation for healthcare practice, encompassing things like questioning and examining and collecting information about a problem or an issue, doing observations and assessments, and gathering personal experiences within the clinical setting. It is not an area of EBP that I think we have leaned into sufficiently as nurse leaders. I think sometimes we see a problem ourselves or get some validation from a few colleagues and jump pretty quickly to formulating a question, gathering evidence, and planning translations. I would like us to do a better job at leaning into this inquiry stage of EBP as nurse leaders. Again, not really the focus of this class as much, but I just wanted to point out that I do think that is a very important part of the process. So this practice question, evidence gathering and translation, the learning and the practice kind of cycle there is a well-honed part of the EBP process. Practice is the translation of what clinicians know to what they do, and then learning is a relatively permanent change in mental process, skill, emotional function, or behavior as a result of an experience. So you can see those two things, practice and learning, really encompass the process of questioning, evidence, and translation. And at the end, the result is hopefully best practices and practice improvements, which might then cycle back to calls to inquiry again. One thing I notice about this model is it is incredibly iterative. Like, there is no clear, one step to another step without these cyclical potential changes. So I think sometimes, when we read about evidence-based practice in the literature, it comes across sounding very stepwise. And that's essentially how we have to describe things in order to make sense of them. But when we implement this in practice, don't get frustrated or feel like you're behind if there's a lot of iteration. Maybe you come up with a practice question, but there's not enough evidence, so you have to go back and revise your practice question. Or maybe the evidence you have a practice question that you don't know the outcomes for, and you have to go to the evidence to refine the question and add outcomes to it. That is completely normal and actually best practice. Kind of jumping ahead, pretending like you know what's in the evidence or guessing is where folks get into trouble, in my opinion. And I wish that we could find better ways to lean into this iterative method of question evidence translation process. And in this course, we will deliberately attempt to lean into iteration with what is called the PET process, the practice question evidence and translation process. So I want to finally describe translation. Translation is determining the fit, feasibility, and acceptability of the evidence and implementing it in the setting, planning, implementing, and evaluating it in the setting. We're going to get into that translation as we talk about writing proposals towards the end of this class. That said, I just wanted to kind of have you understand the bigger context by looking at the full process here before we zoom in and really focus on the PET process, which is kind of the literature review portion of this class. All right, thanks for listening with me, and I hope you are doing well. Please don't hesitate to reach out if you have any questions, any ideas, anything you want to talk about. I really love all of this stuff, and I enjoy chatting with students about it, so please reach out.